Good evening, everyone, and welcome to the very first session of LEJENDO. LEJENDO is the new concept from the Lister Endometriosis team, and it stands for Lister Endometriosis Journal Club. The idea of LEJENDO is to make journal clubs less boring and more interesting. We're all very busy clinicians, and it's always difficult to read all the journals or read all the new papers that come out. And the reason we've chosen our two guests today is that, in fact, the idea of LEJENDO came to me because of these two great people, Professor Roman and Professor Bendifalla. Horace produces so many great works that to catch up with reading those is very, very difficult. So we always thought that, just to read what he produces, we need quite a lot of time. And I listened to Sofiane recently give a lecture on his recent work on diagnosis of endometriosis. And I thought, God, would it not be nice if we can promote this and get more people to listen to works that are published and can sometimes be missed? So that's where LEJENDO idea came from. The format is going to be that we choose around 8 papers each month. And you can see the people behind LEJENDO, which I will introduce to you in a second. And they will do the hard work for you. They will go through all the papers that are published in the field in the last few months, ideally in good peer-reviewed journals with good impact factor, but we're going to look at all papers that come out. We focus on endometriosis, but from time to time, if we find something really interesting on other topics, we'll bring those as well. And then we choose 2 of those papers and approach their authors, usually the first author, but not always, to come and present it themselves. I don't know if it's going to work or take on. It's a start. We're going to give it a go. We have agreed to do it for a year, every month at 6 o'clock on the 6th of every month. If it works, it works. If people like it, fantastic. We're going to keep it free. We have accepted no financial support, although I have to thank Karl Storz UK for their technical support and their help in promotion of the event. And we'll see how it works. Please join the Facebook group of LEJENDO, and let's get the discussions going there. One other thing I need to clarify here before we make a start is that there won't be any time for us to properly critically appraise all the papers. So the idea is that this is like a breakfast show. We're going to just mention the papers and tell you what they found, what they did. And it will be for you guys to then get interested and go and find that paper and read it. Or maybe you will suggest to us then to discuss the paper in more details. That's number 1. Number 2 is the time that our special guests are given to present is not going to be enough for them to properly present their work. So consider that also as an introduction to their work. So I'm going to introduce the team behind LEJENDO first. So we've got Mikey Adamczyk, who has been my fellow for a number of years and now has replaced me on the National Health Service as a consultant gynecologist, and he also has joined me as a consultant in CMIG London at the Lister. Avril Bachi is my current fellow. Kyle Fleischer is my next fellow. He's in the queue. And Ben just finished fellowship with me. And John Flanagan, you don't see, but he's from Karl Storz. And at the moment, we have Professor Roman Horace. You all know, as I said to you, I don't think there are many people that we can mention. I would even go as far as to say in the history of endometriosis that have done as much as he's done for this field. There are other great authors and investigators and surgeons, but I think Horace's name is going to remain there in the history for endometriosis, for the work that he's done. So we're going to start first with the 3 papers that are going to be presented by our fellows. Today, Kyle and Ben are going to lead. After the 3 papers, we'll have Professor Roman's work. We'll do some question and answer. Please use the Q&A feature, and then we'll go back to some more papers, and then finally we'll have Professor Ben Di Falla. So Ben, please make a start.
Okay. So good evening, everyone, and I want to say a big thank you for attending this evening, and what a pleasure it is to speak to all of you. First paper I'm going to introduce in the roundup is a paper produced by a group of researchers working out of the University of Sydney that looked at pregnancy outcomes in women with endometriosis and/or the use of assisted reproductive techniques. So to tell you a little bit about this study, this was a large retrospective cohort study that assessed adverse pregnancy outcomes for women, looking at 4 different groups, one being a control, one having ART alone, one having endometriosis alone, and one having a combination of the 2. And I think one of the key findings here is that there are a number of adverse outcomes that were identified in the endometriosis alone group, including an increased chance of preterm birth before 37 weeks, an increased chance of antepartum hemorrhage, and increased chance of placenta previa. Now, we know that there are increased risks with the use of ART, but actually what this paper finds and is adding to a body of evidence is that people with endometriosis might be a higher risk obstetric group, and we may need to change how we do surveillance for this group of patients.
Kyle, did they say anything about the mechanism of action in there?
No, so in this study, it was entirely an epidemiological study, but looking at this paper, I looked at some of the background data and papers published about this kind of area of research, and actually there's a really excellent TOG article that came out or was published in October of last year, and they've suggested a few potential reasons. So one is changes in the endometrium, resulting in defective implantation. Another was the fact that there is progesterone resistance as well as inflammation, with increased number of inflammatory mediators and cytokines, resulting in defective placentation as well. So those are some of the potential reasons. And like I said, there's an increased body of evidence suggesting that endometriosis, it can be a higher risk group.
Okay, thanks.
So next paper I'd like to talk to you about is one that's been published by a number of clinicians at the University of Bologna, and this has looked at the use of ICG in full thickness bowel resection for rectosigmoid endometriosis in order to predict fistula. So talking about the key findings here, this is a small but promising study of 33 cases, 2 of which were complicated by bowel fistula. And with the use of ICG, I know we've used it in a qualitative way to assess what's the likelihood, how well is the anastomosis working, and what's the likelihood of subsequent complication. In this paper, 2 of the authors did both qualitative and quantitative analysis following the cases, and you can see the sensitivity and specificity applied here. In the next slide, I'm going to talk to you a little bit about what measures they actually use to predict it, and tell you a little bit of background as well. So this study is kind of based off a really interesting study published by colorectal surgeons in the Journal of Minimally Invasive Surgery, where they did a similar study really with 82 patients. And what they found, if you look at the graph slide, essentially, is that there was a risk of slow perfusion when the T-half match, which was the time taken for maximum fluorescence, the time ratio, so kind of the difference in time between the time taking to half maximum and maximum, and then the slope, so the gradient of that. And it found that those were key indicators for risk of fistula. In that study, they used a TR of 0.6, greater than 0.6, to predict fistula. And using those findings, I'm going to talk a little bit about the findings in this paper. So if we look at LP, stands for the lowest point of fluorescence of the proximal bowel, in the two cases of fistula, that was 0.7 and 0.7, so greater than 0.6. And then again in the distal bowel, on the next slide, again 0.7, 0.7. So unfortunately, this study was underpowered, but it shows that potentially this quantitative analysis can be used to predict fistula. Now, I hope I've been able to explain this complex study in a brief way, but this definitely needs some post hoc analysis by our attendees to get their head around it.
Okay. Horace, I know you use ICG for this as well, and I've started doing that. But are you doing any quantitative method, or you just judge it?
No, you're using just the qualitative method, meaning that if we have, by chance, we have an edge of the anastomosis or of the suture which is not colored, we are ready to recut and redo the suture.
Yeah,
that's why I think it would be interesting to, because usually when the surgeons use the ICG, if they see that it's not normal, they redo the anastomosis. So it's difficult to show a fistula because they are doing anything they can not to have a fistula.
Yes. And my worry has always been with ICG that I know that your practice is similar, that we very rarely do an ileostomy anyway. And my worry has been that ICG may make us do more ileostomies, because it hasn't been the case so far, but I guess that's a potential problem.
No, I think that if the color is abnormal, so if you have more gray than green, it is logical to redo the anastomosis and not to put a fistula. So not to put a stoma. So we
stoma, yeah.
Actually we do not longer use the stoma.
Yeah, yeah.
We decrease down to 0%. However,
okay.
7 years ago, when I was in Rouen, we were performing numerous, very high rate of stoma in patients with excision of the vagina and the rectum, simultaneous excision, concomitant excision.
Okay, all right. What next? Is that for you, Ben?
Yes, as a final short abstract, I thought about including this one from Anja Svensson and her team in Sweden, from Skåne. This was published in the European Journal of Obstetrics and Gynecology and Reproductive Biology just last year. And we all know how long it takes for a diagnosis of endometriosis, still 7 to 10 years. And there is such a push for trying to diagnose endometriosis earlier. And this team looked at TSH receptor antibodies as an aid for the diagnosis of endometriosis. As you can see, this is a cross-sectional study that involved 172 women with surgically confirmed endometriosis, and they compared it with control groups of 50 healthy women blood donor and 114 women from the Malmö offspring and general population. They didn't look just at the TSH receptor antibodies. They looked at other markers and antibodies, including, for example, the FSH, the LH, HCG, the AXIN1. And what is really interesting that you can see from this table is when the detection limit was put at 1 or more for the TSH receptor antibodies, 29% of women were presenting with positive, with endometriosis were positive in comparison with 2.6%. By lowering the detection limit to 0.3 or more, actually 94.5% of patients with endometriosis were resulting as positive in comparison with 7.9%. We're talking about IgG in general. And what is really interesting is that there wasn't really any variation on the TSH receptor antibodies if it was compared with the duration of the disease or the severity of disease, and they were influenced by the other factors such as, again, the FSH, the LH, the AXIN1. So this study was really interesting and promising as an aid for the diagnosis of endometriosis, and it goes really well hands in hand with the presentation that Professor Bendifalla is going to do soon.
Yeah, that's really interesting. And there were a couple of other papers that I've seen that link endometriosis with other autoimmune diseases. And I'm in fact inviting Marina Kovaskov to come and present one of those papers. It would be interesting. We see quite a lot of that in our practice, but this is all promising. Okay, well, thanks, guys. Let's go to the exciting part of the day, and I have already introduced my very good friend, Professor Horace Roman. I have been familiar with his technique, initially called Juan technique, for a number of years, and maybe I will tell you after his presentation what we did in Iran almost in parallel. But he has been really championing this technique, and we have now started doing that in the UK in the last few years as well. I'm really keen to hear what he and his team have found and what was in the publication. Please, Horace.
Thank you very much, my friend. And I am very pleased to present you this, this article, which focuses on one of my favorite techniques to treat the colorectal endometriosis, which is the disc excision. So everybody knows that the colorectal endometriosis surgery may use three major techniques: the shaving, the disc excision, and the segmental resection. And in our practice, so in our center in Bordeaux, in our institute, we use the disc excision in 1/3 of patients. So you can see that we use in a balanced manner the shaving, the disc excision, the colorectal resection. However, the disc excision is 1/3 of patients. The disc excision means that you remove the nodule, you open the bowel, and then you close you suture, you pair the bowel by either stitches directly or by staplers, using the circular stapler, the most used worldwide, or the contour transstar stapler, the Rouen technique, which is less used because we could not teach this technique actually to our colleagues coming from elsewhere. And the goal of the disc excision is to perform a complete excision of the nodule and to conserve the bowel, so to avoid the bowel denervation and the variation in length and volume of the rectum. We have already published several papers where we investigated the functional outcomes after the disc excision, and we observed that functional outcomes are good. In some cases, we compared with colorectal resection, but anyway, we observed that if you perform a disc excision, you have never stenosis after the surgery. You do not expect variation in rectal length, so probably with low risk of LARS. And anyway, the mesorectum is completely preserved. So recently we published the largest series of patients managed by circular stapler. So the stapler which is usually employed to perform the colorectal anastomosis. So we counted 492 patients until July 2022. So I enrolled the patient I managed from 2011 to 2018 in Rouen, so my former department. So I was the unique surgeon. And now we are 3 surgeons in Bordeaux. So we also enrolled all the patients managed from 2018 to until July 2022. So 492 patients with nodule, which may vary from 1 centimeter to over 3 centimeters. And in all the cases, we use the full thickness disc excision using the circular stapler. So here you see that these patients represented 24% of 2,029 women managed for rectal endometriosis during this period of time. So as expected, the women were young, 30 years on average. 25% of them have already had a previous surgery, and most of them were nullipara. They were symptomatic, as you can see in the case constipation score and Jiggly score, and 2% of them were also subocclusive. So we treated by disc excision also very large lesions. The mean operative time is 2 hours. Now we are, maybe it's few, it's about 1 hour, 1 hour and a half. And you can see that the majority of cases, in the majority of cases, the nodule involves the mid and low rectum. So this is specifically the nodules where we do anything we can to remove by disc excision instead of low colorectal resection. And in 2/3 of cases, the nodule was larger than 3 centimeters in length. In 33% of cases, there were also vaginal infiltrations. The height of the rectal suture is about 9 centimeters, and the diameter of the rectal patch is over 4 centimeters. We use the protective stoma in 18% of cases, but more in cases managed in Rouen, and actually we do not longer use it in Bordeaux. Now, we recorded 4% of rectal fistula, meaning that the rectal fistula after disc excision is comparable to that after colorectal resection. We, however, observed that patients with fistula had a lower nodule, meaning the suture was 6 centimeters above the anus, meaning the mid-low rectum, when compared to those who had less fistula no fistula where the high was 9%. So we demonstrated what we know, that lower the nodule, higher the risk of fistula. Which is very important to understand that when you remove a disc excision, if you ask two pathologists to look for the foci on the margins, on the edges of the disc, he will find foci in 30% of cases. However, in this area, the rate of clinical recurrences, rectal recurrences, is 0.6%. And I mean about rectal recurrences due to on the level of the suture, actual recurrence, not nodule elsewhere on the bowel. And 2 of these recurrences were treated by medical treatment, so they feel okay, and 1 of them had a colorectal resection. So the conclusion of this study is that the surgery of endometriosis should be done minimally invasive approach. So in my opinion, it is not affordable to open the abdomen now to treat the endometriosis. The disc excision is feasible in 33% of cases, and in 2/3 of cases, the nodule were larger than 3 centimeters. So this threshold of 3 centimeter diameter nodule, you can find it everywhere in the literature. I don't know where this threshold comes from. because for us it's not a limit. You can remove larger nodule by disc excision if you perform a very deep deshaving. And I think, in my opinion, a balanced use of free techniques is for me a landmark of the experience of a team involved in deep endometriosis surgery. And you can see a myriad of this technique on my LinkedIn, Facebook, YouTube accounts. I used to publish every week 2 or 3 full-time movies, so you can feel being with me in the operative room and with the goal of training. So thank you very much for your kind invitation. I hope I respected the time.
You certainly did, and I'm very, very grateful to you. That's absolutely amazing, Horace. I want to ask you a question that I'm sure you've thought about. It's about fistula, and we've been thinking about the definition of fistula. If you have, first of all, let me ask you this. 20 patients had fistula in your group. Of these 20, do you remember how many presented within the first 2, 3, 4 weeks of surgery, and how many were late occurring fistulas?
In my opinion, in my experience, the fistula occurs within the first 10 days.
Okay.
So the top of the fistula, the top of the curve is 5 to 6 days.
Yeah.
One patient had a fistula at the day 12, but I have never had fistula over.
And these are the fistulas. Okay, let me put the question in this way. The definition of fistula is a connection between 2 hollow viscera, usually epithelialized. If you have opened the vagina or have done a hysterectomy and you have a leak, and therefore you get the bowel contents coming from the vagina, I'm assuming that you're counting that as a fistula, correct? Now,
yes.
I want to put to you, and this is something that me and some of our colleagues have been discussing in length. I want to put to you that that's a leak, not a fistula. A fistula, in my books, is when 2 hollow organs find a connection between them, and that's usually a long term. What do you think about that?
Yes. I discussed this in a paper published 2 years ago in Human Reproduction with a series of fistula and leakage, because in our experience, in 2/3 of cases, when we have a leakage, we have a fistula, meaning that the vagina has already been also been excised, so the two scars are in contact, and we have the fistula. And then in 1/3 of cases, we have leakage because the vagina was not open, so the stools go outside into the abdomen. And there are 2 very different clinical presentations, because the patient with rectovaginal fistula are not in a danger because the stools go outside. So they feel good. They just say, I have gas and I have stools through the vagina. Okay, we put a stoma. The patients with leakage have a peritonitis, and one of them was hospitalized 2 weeks in intensive care. So the clinical presentation is much more dangerous with the leakage. But when you look at the healing, patients with leakage, once you put the stoma, in 80% of cases, the healing is spontaneous. While in patients with rectovaginal fistula, you put the stoma, but the healing is never spontaneous. You have to do 1, 2, 3 procedures through the natural route, or you redo the surgery. We also did, in 5 cases, we have to do the delayed colonal anastomosis. I don't know if you know what it looks like. It's a very complex procedure where the rectum is pulled outside through the anus, and during 2 weeks, the patients stay like this, and after 2 weeks, we cut the rectum, and in this case, there is no longer a fistula, because you bring the sigmoid colon just below the vaginal the vaginal scar.
Mm.
So to repair a rectovaginal fistula is much more difficult, and the stoma usually is maintained for 6-10 months or more. So there are two different situations. But when I said fistula, I counted in this paper in a wrong way. I counted together the fistula and the liquidus.
Okay, well, maybe that's something that we can discuss further another time, because I think maybe an agreement on the definition should be, because you're absolutely right, the clinical presentations are different.
Completely different.
Yeah. Avril, there is a question. Do you want to read that
Yes.
question?
Yeah, thank you so much for the presentation. You mentioned just now about the low risk of recurrence with this excision, but one of the audience wants to know, how did you define recurrence? Was it based on the patient's symptoms or MRI findings?
Yes, it's a very, very good question. So in my practice, I never perform MRI just to attend the patient far from the surgery. So if she is clinically perfect, I do not do the MRI, because post-operative MRIs were very difficult, very challenging to read. So the patients with recurrence or symptomatic patients. So in these symptomatic patients, I saw them back, I examined it, and I stated that they have recurrences on the MRI. So all of them, the 3 patients or patients which are symptomatic with an MRI which is positive. So maybe we rule out very, very small recurrences, 5 millimeter, but clinically and MRI positive recurrences, we have only 3.
Okay, I must have missed this, but how long was the follow-up for the patients?
In this area is more than 3 years.
Okay.
But the longest follow-up is 11 years.
Oh, wow. It's really long.
That's really, really impressive. Well, thank you very much. What we're going to do, we have another 3 short papers, and then we'll go to Professor Bendifalla, and then we'll hopefully close in time for 8 o'clock France time and 7 o'clock UK time. So Kyle, Ben, what do you have for us? You're mute. Ben, you're on mute. You're on mute.
Here we are.
Ah.
Can you hear me now?
Yeah.
Oh, perfect. So the first paper that I have here is not about endometriosis, but it's such an important, good paper that I thought we had to include it. So it's from Gillian Halley and her team from the British Columbia, and was published just in February of last year, and looked at the outcome for opportunistic salpingectomy for ovarian cancer prevention. And it's a very big paper. You can see that is retrospective between 2008-2017, but involves 60,000 people, 26,000 of which had opportunistic salpingectomy, and 32,000 were our control group. And what we looked for is like if there was any reduction for serous cancer, epithelial ovarian cancer, breast, colorectal cancer. And it's really interesting, as you can see from the table here on the left-hand side, there was a significant reduction for both serous and epithelial ovarian cancer in the opportunistic salpingectomy group. I mean, if you just see at the serous cancer between the expected and observed, there is a massive difference. There wasn't any observed cancer in this opportunistic salpingectomy, and there was more than a half reduction in epithelial ovarian cancer in the opportunistic salpingectomy. On the contrary, in the control group, there were 15 serous cancer and 21 epithelial ovarian cancers. Another thing to note is that there is actually no difference, so there is not really any reduction in the other forms, in the other cancer, like, for example, the colorectal cancer and the breast cancer. And so this paper raised the question, like, should we do more of these opportunistic salpingectomies? Okay, that's really interesting. I'm going to launch a poll for everyone to answer. So I want to know, how far do you guys think we should take this?
we all know that, you know, taking the tubes is a good thing, but how far should we go? A, in all patients who are having a hysterectomy. B, in this group and all patients undergoing benign gynecological procedures when they've completed their family? Or should we go even further and say general surgeons should learn how to do a salpingectomy when they take somebody's gallbladder out? Or maybe you would go as far as, actually, if a patient comes to me and say, doctor, I want you to reduce my risk of ovarian cancer, it would be acceptable to do a bilateral salpingectomies. So I will just wait a few seconds for everyone to answer. 22 people have answered. So let's have a think about it for a second, because I think it's an interesting one, and it comes with the second poll, which will ask a similar question. So let's see what people say. So that's interesting. Around a fifth of the audience thinks that it would be okay to offer a salpingectomy to a woman who says, doctor, I want you to reduce my risk of ovarian cancer. And interestingly, only 13% think that we should teach our general surgeons to take a fallopian tube out. Sofiane, what do you think about this? I don't know if Sofiane can hear us.
I hear you, but
yes.
Sorry, I was not listening because I was responding to my colleagues. But sorry, I can give you my opinion. Sorry.
Yes, please. Huh?
Shane, can you just repeat the question, please?
Yes, so I want to know, in your opinion, how far should we go with removing fallopian tubes when we do surgery? We know that, you know, during a hysterectomy, of course, you know, we'll take it. Is it okay to teach general surgeons how to remove fallopian tubes when they do, say, gallbladder surgeries? Or do you think it's even acceptable to remove a fallopian tube electively in a woman who says, doctor, I want my cancer risk to be lower. Please remove my fallopian tubes. What's your opinion?
In our opinion, because we work about this topic in French recommendation, because as you know, the College of French asked this question, and about this issue, we decide, and based on the literature, to remove all the part of the tubes in this issue when you perform hysterectomy for benign pathology or for another question. And to give you my opinion, I followed the recommendation of the college in this topic.
Okay. What about you, Horace? What do you think?
I think that if the patient has a pelvic or an abdominal procedure, and I propose her, if she finished, if she's 40-year-old and she does not longer intend to get pregnant, I used to speak her about this problem and to propose her to remove the fallopian tubes.
Do you think teaching general surgeons to do fallopian tube surgery when they're doing gallbladder is too much?
No, it is not too much, but the general surgeon think that they know removing a fallopian tube. So I don't think you need them to touch. I saw the general surgeons removing ovaries, and this is they consider that this is very simple surgery.
Okay. Yeah.
I think we can inform them, but we can teach them. But most of them think that they are absolutely able to do this.
Okay, so that's interesting, the result of the poll. I'm going to just put another poll, share results. I don't know if everybody can see this. Can you see the results?
Yes.
Okay, so that's an interesting one. I'm going to now share another poll with you, which would be interesting to see. Let me see if I can do that. The second poll. For female sterilization. I don't know, did it work? Did it not work? Launch. Okay. For female sterilization, Should women be offered bilateral salpingectomies rather than clip application or tubal ligation? I will just give it 1 minute. Okay, so most people think yes, 96%, 93%, 89%. Okay, that is also interesting. Let me just end the poll and share the results for people to see. That's not surprising. I think that's interesting to see. All right, let's go ahead. All right, this is a very controversial study for many reasons. It's probably a good time for me to say that we don't necessarily agree or endorse all the studies that we bring to LEJENDO. This is a study that you cannot ignore. You know, this is a large RCT. Yes, of course, you know, funded by the industry, but it's a Lancet paper. So whether or not you agree with the findings or whether or not you are someone who uses medical treatments for endometriosis, that's irrelevant. I think it's a very important piece of work that needs to be discussed. So what did they find?
So this was published in the Lancet. The original findings from the Spirit 1 and Spirit 2 studies were also discussed at the SRM Congress in 2020. So this was put out by clinicians predominantly from the USA and California, but really from clinicians all over the world as well. So this is a paper that consists of 2 phase 3 multi-center RCTs that were replicate studies. And participants were allocated to either a placebo group, a once daily combination therapy group, which consisted of relugolix, estradiol, and norethistone, and then also a delayed therapy group, which received relugolix alone, followed by 12 weeks of combination therapy. The primary endpoints were determined at 24 weeks, and the primary endpoints were decided to be responder thresholds to identify the magnitude of change in the numerical rating scores that was actually meaningful to patients, which I found interesting, but also looked at, was there a decreased use of analgesics? So with the relugolix combination therapy, as well as the delayed therapy, there was a significantly greater treatment response for the primary endpoints. Other positive findings that the study found that there were minimal hypoestrogenic effects. In the combination therapy group, there was less than 1% loss in bone mineral density. We do need to be mindful, as you said, Mr. Ghazali, that this is an industry-funded paper, but it does offer a potentially new non-surgical intervention to individuals who may find surgery unacceptable or non-preferable, or even in those who surgery is not possible to do for other medical problems. Other things that are happening, there's an extension study being done to determine the length of time this medication can be taken. And other things we need to consider is whether there is a benefit over the current alternatives, such as GnRH analogs with add-back HRT.
Okay, that's interesting.
So next study I have for you, again, clinicians from Italy, from both Rome and Bologna, and this looked at outcomes in patients with nerve-sparing posterolateral parametrial excision for deep endometriosis. So this was a retrospective cohort study. It was multi-center, and it divided patients into a P group where there was parametrial involvement that required posterolateral parametrectomy, and those without parametrial involvement. And they looked at a number of different functional outcomes prior to and in 3 months follow-up following surgery. So in the P group, there was more likely to have dyspareunia and sexual dysfunction compared to the NP group, and this was a significant difference, but overall there was an improvement between pre and post procedure. In terms of voiding dysfunction, 6 patients in the P group compared to 0 in the NP group had voiding dysfunction post procedure, but this was found to be non-significant. This is a really comprehensive study, but may benefit from a slightly longer follow-up. I think the findings reflect the complexity of surgery required and endometriosis within the parametrium, and may reflect that even though the hypogastric nerve is spared, this is still a nerve plexus that might be involved.
That's interesting to hear. Horace, what's your experience? Speaking to some of my colleagues, they tell me that they teach all their patients self-catheterization. That's not been necessary in my practice, although from time to time patients need recatheterization, but I can count patients who needed self-catheterization with one hand, actually less than that. Ben, I think we've had 1 or 2 maybe ever. What's your experience?
Well, there is very rare that we ask to patient to learn the self-catheterization before the surgery. Maybe in patients with bilateral parametrial involvement, or in patients who do not void the bladder before the surgery, because if you ask the patients how they void the bladder, in some cases you understand that they need to push, and in some cases you will see on the MRI that she said before the MRI I void the bladder, and you see a very full bladder. In this case, I asked them to perform the self-catheterization before the surgery. But I think I perform at least 2 or 3 surgeries on the parametrium a week. However, the parametrium, it's such difficult to define anatomical situation. So I think the most difficult cases are there where you remove the parametrium below and outside the ureter. So when the ureter is suspended above a vid. And a second case where it is very, very challenging for the bladder function is when you have to go on the sacral root. So when you see the sacral roots, it means you had to remove a piece of the inferior hypogastric plexus. And I think that if you speak about the parametrium, I think we have to share the patients in 3 groups. So you go onto the parametrium, so laterally from the uterosacral ligaments, but medially or below the ureter. Second group outside the ureter, and the third group where the sacral roots are seen, so dissection until the sacral roots. And I think the risk of bladder dysfunction is increasing from the first group to the second.
Yeah.
What about this group with parametrial disease that is lateral to the uterosacral ligaments? Do you do any urodynamics on them before the operation at all?
No, I rarely do the urodynamics before the operation, because I think I do it only when I feel that the bladder dysfunction is very severe. So in order to show her that we have a bladder dysfunction and to understand how it works. But usually I do not do it because first, it is not pleasant. It's not a glamour to have a the urodynamic test. Second, it does not predict if your patient will require not a self-catheterization when she feels that she voids the bladder. And third, if you have a nodule on the parametrium and it's painful, you should anyway remove it. So with or without urodynamic test, and in majority of cases, I know what the urodynamic test will show. It show a hyperpressure of the urethral sphincter, so a hypertonia of the sympathetic system. So no, I very rarely perform the urodynamic test prior to the surgery. I think that the patient have a lot of exam to do, the MRI. So I prefer not to do it.
Yeah. Okay. Well, thank you. And let me introduce our second featured speaker, who also was part of the reason that we started this project. I listened to Sofiane not that long ago, a few months ago, speaking about his work on how using AI and how using the same technology that was used to develop the COVID vaccine can help us in detecting endometriosis. And I have to say, I've listened to lots of talks like this, but this was so different that it was heartwarming to think that something really proper is being done, and maybe not that long from now, we'll find the answer. Sofiane, thank you very much for accepting my invitation, and please, you can share your slides.
Thank you, Sharwin. It's a real pleasure to be here with you and to share this presentation with so famous surgeons and doctors, and thank you for the invitation. I will talk about the microRNA salivary signature and about the topic very interesting for all of us, which is the endometriosis diagnostic. Maybe just at the beginning to just take my time. At the beginning, we talk about to present about the first study, which is what we published about the microRNA signature on the blood. And I'm going also to talk about the microRNA signature on the saliva, because this is a real innovation in this topic. 98%, this is accuracy, which was obtained on the saliva with the combination of microRNA and artificial intelligence. And 10 years is the delay that you know to obtain a diagnosis for endometriosis, and this delay is now reduced to 10 days because, as you know, with just a saliva sample, we can give you a diagnosis, information about the presence of endometriosis, yes or no, in a few days. And why talking about this subject? Because you know endometriosis is a real matter of issue, especially for the diagnosis. I'm going to discuss how we obtain this result and also what is the impact for the next months and the next years. Endometriosis diagnosis concerns millions of women. As you know, the delay, the mean delay, whatever the expertise of your radiologist, whatever the expertise of your sonographist, whatever the healthcare system, it took 10 years. And those 10 years, in those patients who need to have a diagnosis, we know that 25% need laparoscopy to obtain this diagnosis. We also know, because this data came from UK, that all the information and the pathway associated with the diagnosis is so complex, and we know that this experience for patient is associated with many difficulties, and that explains why it is an issue for patients, but also for doctors. And we know all that to obtain a diagnosis sometimes, especially for early stage, but not only for early stage, because you know there is women with heart disease, with colorectal endometriosis, who need maybe more than 3 MRI to obtain a diagnosis, and to need to see doctors and GP and specialized doctors more than 5 or 10 times. Those results came from the data from UK. And because we know this topic is a real challenge, this topic is a real challenge for us, doctors, but also for patients. And this challenge was, until few days, considered as impossible. In this topic, you know that MRI, sonography, and surgery are the most important tools to obtain the diagnosis and are considered as in the guidelines has the key solution for this diagnosis. And as you know, if I can highlight two numbers, the sensitivity for surgery and also for MRI is not over than 25%, and the specificity is not over than 85%. And with those numbers, we can discuss for early stage, late stage expertise, but all, this is a mean. And in this mean, we know that diagnose is associated with suffering, investigation, and discrepancy. And this discrepancy has to be explained to patient. And as you know, we have all in our office patient with pain, clinical exam with no endometriosis, MRI with no endometriosis, and at least if we perform laparoscopy, we can find endometriosis. How we obtain this 98% of accuracy? Because we connect the dots, and the dots are published since several years. What are the dots? Dots are MRI and are EA and microRNA. What we know about EA? As you know, there is two publications. One came from Mustafa and the other one came from Atker. They show that using statistical tools other than logistical regression, new statistical tools are really impressive to improve the accuracy of the data, especially when you have a high number of data. And using IA is for us the same technology that you have in your phone, in your smartphone. When you use the facial recognizing of your phone, you only need some point, not more than 100 points to recognize you. And this technology can be used in every domain, and especially to deal with our data and the huge number of data. MicroRNA are known since a long time to be between the protein, the RNA messenger, and be used to be impacting on the DNA information. And why microRNA are so interesting? Because many data are reporting that those microRNA are associated with mechanism and physiopathological pathway for many diseases. And I can show you several papers about that, especially for us in endometriosis, about proliferation, neoangiogenic, apoptosis, and, as you know, inflammation. And when we took those dots, we know that this paper is a really interesting paper, because in this paper, this is a review when we can read that some microRNA are associated with the mechanism of the physiopathology for endometriosis, especially in the blood and especially in endometrial tissue. And when we look all those data, we know that only 200 microRNA have been published, not more. What give us Mustafa? Mustafa show if you made microRNA sequencing in the blood, you can find a combination, 6 microRNA able to make a diagnosis with a high accuracy. This is the dots. But recently it has been published, this famous paper from Monaca, and Monaca made the review of all microRNA published in the literature since 20 years. And what she concluded, she said, none of those papers investigate saliva and microRNA in saliva. This is what we did. And we made a study when we analyzed for 200 patients, blood and saliva. What we found? At first, we focused on the blood, and we demonstrated that when we performed the sequencing of all microRNA, all known microRNA, more than 2,600 biomarkers, we can define a signature, which is the combination of almost 100 biomarkers with a high sensitivity and a high specificity and a high accuracy. This is what we found in the blood, and those results are in line of Mustafa's result, but what we did more, it is we use more biomarker because we perform the sequencing of all known biomarkers, especially for microRNA. And what we had the saliva, and in the saliva, we do the sequencing of all microRNA. And what we obtain exactly the same result, the same sensitivity, the same specificity, and for all stages of endometriosis, especially for early stage, we can talk about that after, and for all stage, also for late stage of endometriosis. And this reliability, especially in the stability of the saliva, was for us more interesting than the blood. We also made the correlation between what we found in terms of microRNA, but also what we found in terms of physio complex disease, and this complex disease can be described with the following picture. What we can see, we saw that if we took the picture of one patient to define the signature of one patient, this is the physiopathological pathway of this patient. And we can underline that this complexity can be now drawn thanks to many microRNA. And as you can understand, if we can now personally draw the picture of a patient thanks to microRNA to define their physiopathological pathway, we are close to the phenotype, not the clinical phenotype, but the biological phenotype. For those who are used to work with patients with cancer, this is the same way of thinking. In cancer, we have the clinical data, we have the biological data, and as you know now, thanks to the biological data, we can describe more precisely patient, especially to define the phenotype. This is what we can do with microRNA. We do this work for the fertility, and we show that it is possible now to define a signature to find the phenotype of infertility for women with endometriosis. What is the impact? For us, the impact is simple. We will now focus not on the diagnosis, which will take 10 years because we can reduce this delay, to focus on patient, to focus on pain, to focus on quality of life, and to improve the care pathway. This is, for me, the most important thing in this innovation. The other way of thinking, you can now reduce the rate and the number of laparoscopy, of useless laparoscopy, to focus on laparoscopy, especially to treat endometriosis if it is needed, not to diagnose. And at least, because the issue is really important, we focus on the issue of the impact for the society, the impact for the medical impact for the patient, and we demonstrated that when we focused on the willingness to pay, and when we add this information in a care pathway, we start with the French care pathway, and we compare the test with the MRI, with the surgery, with the sonography, and with several care pathways usually done in our strategy in France. And what we demonstrate that whatever your strategy, when you use the on the test at the start for the diagnosis, you are more cost effectiveness. To conclude, of course, I show you the data of two studies which have been published for one study, one prospective study, and we need a level of evidence more important. That's why we perform 1,000
I think there is a problem with the connection, Sofiane. Do we still have Sofiane? No.
So he's speaking until he comes back.
Yeah.
So he's speaking about a multi-center study with external validation. And we were involved. There were 1,150 patients. So the last patient was enrolled last week. Sofiane?
I don't know if you, yeah. Sorry.
No.
You hear me? I don't know
Yes,
if you...
yes.
The reliability of the saliva, it will be interesting to discuss about it. The simplicity is just a saliva sample collection, and it is non-invasive, which is for us the most important. And because we believe...
yeah.
And we lost you when you started the slide with the multi-center study.
Sorry.
In 1,000 patients.
Yeah, the multi-center study for us is really interesting because we finished this study, and thank you, Horace, to help us to finish this study, because as you know, we include more than 1,000 studies in less than 1 year, and the data are now starting to analyze, and we hope to write the paper and to give in the next months the data for all of us. And this is the next step.
That's just absolutely brilliant. Sofiane, did I see correctly that you said specificity is 100%?
Yeah, the specificity is 100% on the data of the two first 100 patients. But We have to just, I can give you the specificity in the interim analysis, but the specificity is really high, higher than what we obtain in MRI and surgery.
So that, in another word, is that if your test is positive, if your test is negative, you can tell the patient with certainty, almost certainty, that they don't have endometriosis. That's really important.
Almost, yes.
Okay. Well, that's going to change something.
This is important because we see every day a lot of patients who come back, I have an endometriosis, I have an endometriosis, and actually they're not patients for us. They have chronic pelvic pain, anything else. So thanks to a test like this, we can stop to see them every 2 months because they have anything else than endometriosis.
Okay. Well, that's really good. Thank you very much, Sufyan. I think there are a couple of questions. We're running maybe around 8 minutes late. That's mostly my fault.
Shane, if I can just add one thing.
Yes.
Because we believe in the saliva and in the RNA, we are going to launch a 3 study in the next days, next months, for the center who want to participate. I give you my email, and you can join us if you want. We launch a study for the teen women endometriosis in the gynecological pathologies for all gynecological, pathological, and in cancer and in ovarian pathologies. Thank you very much for your.
No, so there is a question, Avril, if you want to read Lone's question. Lone Hummelshoy, who I'm sure most of us are familiar with, is asking a question, which I think you already answered. Avril, do you want to read the question?
Yes, so the question is whether or not this test has been replicated or validated in a different cohort. But you mentioned that you're doing a multi-center trial and the data is coming out in a few months, isn't it?
Exactly. We published the first study last year, and we launched after the first data because we had a really good data, the multi-center validation study, and we hope to publish the interim analysis in the next few days and the all data in the next few months.
That's good. And another couple of questions. So you mentioned about the 100% specificity. Does that mean that this patient does not have active disease at the moment, or does that mean she will never have endometriosis in the future? Same with if it's positive, yeah.
Oh, this is a wonderful question. I can't answer it. I can make hypotheses, but if you remember, I think all of us, you know, this picture of Nizol and Donez about the tubes, the cellular, and the endometriosis, which is at the beginning blue and white, and at last, which is not here. And I just can tell you with microRNA, we can say you have endometriosis, yes or not. Of course, we are working about the evolution in time. Of course, we are working about the prediction at different moment, but now I can give you this answer. I only can give you a hypothesis.
Okay, what about if a patient has adenomyosis? Would this be positive on the saliva test?
Sorry, Avril, do you mind reading the person's name who has asked the question as well?
Okay, sorry about that. So Alvaro Bedoya Ronga has asked us whether or not the saliva test would be positive in presence of adenomyosis.
This is a really good question, because in the first study, when we developed the study, we exclude adenomyosis women from the study. But in the validation study, because now we focus on the phenotype, because we know the diagnosis is now obtained, we are sure about that. We've now focused about the phenotype. And I will be soon in the possibility to give you the phenotype of endometriosis and adenomyosis women, thanks to microRNA.
Okay, well, we're looking forward to those results. Mr. Ghazali, do we have time for one more question or not?
Yeah, I think let's do one more and then we say goodbye.
Okay, right. So one last question from Oscar Barnick. So for patients who tested positive for the microRNA but had negative MRI or laparoscopy findings, did they go on to develop disease in the future?
This is a major question. I can't answer to this question. I can't answer. But when we will have the data of teenage women And when we follow these teenage women, we can maybe answer to this question. But I am not sure because we need to perform laparoscopy to all these women many times, and it is not acceptable, actually.
Okay, thank you very much. Mikey, do you want to say a few words and then I will close? You're on mute.
Sorry for that. Thank you very much, everyone. This was very interesting. I think we spot on with our journal club. At least myself, I really enjoyed it. I really enjoyed the presenters. Professor Roman, thank you very much. That was great. Professor Bendifala, that was another amazing talk. Thank you very much for joining us. Just to remind everyone that we will be running them monthly. It's the 6th of every month at 6 o'clock UK time. Please join us on Facebook for more information. And we're looking forward to seeing you next month.
Thank you very much. Next month we will have Gabby Moad and Marina to be confirmed, and it will be another good meeting. Thank you very much for joining us.
Thank you. Goodbye.
Goodbye.
Bye. Have a good evening.
Bye, thank you.
Bye, everyone.